Good afternoon, everyone. I have 2 o'clock on my clock, so I think we'll go ahead and get started. My name is Kathy Nickham. I'm the Education Director for the DPC EdCenter, and I am happy to welcome you to our April webinar on recognizing, managing, and eliminating barriers to home dialysis. As a reminder, all of the lines are muted. Throughout the webinar, you can type questions in the chat box, and they'll be answered at the end of the program as time permits. I also wanted to let you know that the recording, and did notice someone already asked this question, but the recording and the slides will be available in about a week. They'll be posted to our website. And I also encourage you at the end of the program, there's a very brief feedback form. It would be great if you would complete that, give us your thoughts, suggestions, other topics that you would like to see in the future. That would be much appreciated. It is my pleasure at this point to introduce you to Dr. Shaminder Gupta. I have to say I met him sort of through, I read one of his articles and I was so taken by it that I contacted him, and we've been communicating ever since. I really appreciate it and like the way that he approaches home dialysis. He is the Associate Chief Medical Officer of Monogram Health. He has served as the immediate past president of the National Kidney Foundation of Louisiana and the lead for its home dialysis task force. He practices in Houma, Louisiana, and serves an indigent population of which 40% of his patients utilize home dialysis. And I think 40% of his patients using home dialysis is pretty amazing in and of itself. So at this point, I'd like to turn the program over to Dr. Gupta, and we'll learn more about how he's done this and what kind of barriers there are and what you can do. Dr. Gupta?
Yes, good afternoon, everyone. Thank you, Kathy, for that introduction, and thank you for the invitation today to participate in this conference. It was great that we met that way, and I'm very happy to contribute to this discussion. And I'll just give a brief introduction of myself, and then we'll jump right in. And please, at any time in the presentation, put your questions in the chat box, and we'll leave plenty of time at the end to discuss anything specific. And it sounds like we have a pretty diverse audience, so hopefully this appeals to all providers, nurses, patients, et cetera. So our first slide, today's goals are to review innovative approaches to options education for renal replacement therapies starting in CKD stage 4, to review perceived barriers to home dialysis, and review approaches to increasing patient empowerment, of which I'm a big proponent. So briefly about myself, I'm from Louisiana, born and raised, and I've practiced in a very rural part of Louisiana, south of New Orleans. Many people don't realize there are cities south of New Orleans, but there are. And I practice in one of those small towns that serves a large indigent care population. I started building my practice back in 2004 and started building my home practice in 2008 in the aftermath of Hurricane Katrina, really long before the dialysis bundle and long before any of the CMS-related changes we all practice under today. And I did it out of necessity for my patients who struggled with weather events every year, transportation, and other social determinants of health that impacted their care. And I built it with the help, obviously, of nurses who are very caring, as well as administrators who also supported our programs. So I'll weave that into the presentation as we go through today. And I've taken this principle and approach to a larger scale now with Monogram Health, where I serve as the Associate Chief Medical Officer, and we implement this methodology across large populations of rural, underinsured, and high-risk members across the country currently. So I'm proud of that we've been able to bring this to a much larger audience now. So we'll jump right in and start with how to approach options education. Currently, options education tends to be outsourced to large dialysis organizations, and I'm a firm believer that sometimes physician-led education can be much more meaningful with the assistance of dedicated home dialysis nurses and administrators. I believe that starting early in CKD4, long before patients need dialysis urgently, is a good way to start, and utilizing direct education in this area, patient to patient, I like to have my patients who are currently on dialysis, who've been through what a CKD4 patient has been through, help demystify the experience of home dialysis. We couple this with a dialysis center visit, which demystifies the dialysis experience. As you can imagine, many of our patients have an understanding of dialysis because as dialysis tends to travel or exist in groups of patients, sometimes someone's had a loved one or a family member on dialysis, and most likely hemodialysis. So their perception of dialysis is usually different than what home dialysis provides. And lastly, offering support. I always try to put myself in the shoes of my patient and being given this information and how traumatizing and how much uncertainty it must bring to that patient and their family in that instant. And we try to understand that this patient may take some time to understand exactly what's happening to them and how to support them in their decision-making process. So early education. So as patients are seen in clinic, we can all attest to, those of us that see patients in the office or those of us that take care of dialysis patients, many times patients do not link their symptoms with advanced CKD. Many times they say, I feel fine, I'm just a little tired sometimes, or have vague complaints that in single instances could certainly be just a single illness, but when you combine poor sleep, fatigue, and other complaints, it's usually a result of advanced CKD. I often hear dialysis. That seems extreme. Can we do anything else to reverse this at this point? And as we know, unfortunately, many times we cannot reverse illness once we get to that stage, and we have to prepare the patient that dialysis will be necessary if they're candidates while they're preparing for transplantation. So I think understanding the illness as being asymptomatic in general is crucial for us as clinicians, so that when we approach our patients, we come with that perspective that they may not perceive they have an advanced CKD type stage. So many practices utilize large dialysis organizations' educational models, and I don't think there's anything wrong with that. However, I firmly believe, and we do this at Monogram also, I firmly believe that dialysis may not be the right option for everyone. So it's important to recognize those that are candidates for dialysis. So if you have an elderly patient with advanced comorbidities or not able to care for themselves, maybe conservative management might be appropriate for that member. And I think physician-led education can be much more objective in that way. But in those members that require dialysis, I have those patients set up a time to come see the dialysis clinic again, long before they actually need dialysis, at least 6 to 12 months before in my estimation. I have them visit the dialysis clinic on a day when we're having a home dialysis clinic. So they get the ability to come in when they're not symptomatic, see a patient who also likely looks well but is on dialysis, and who's likely in their shoes about 9 to 12 months earlier, who was suffering or dealing with the same emotional issues that this member might be dealing with. They get to engage with the dialysis center staff well in advance. This includes the lead nurse, the facility administrator, the dietitian, social worker, and anybody else associated with the care in that center. They get to meet other patients on home dialysis and their spouses and their family members. So I have been fortunate, as Kathy alluded to, I have a large home dialysis population. And in that population, I have patients of all different backgrounds, ages, races, walks of life. And I'm able to pair the prospective patient with someone like them, and I actually let that patient, with permission of the existing dialysis patient, see the visit, see how we see that patient, see the peritoneal dialysis catheter, and then I often leave those patients alone with one another to discuss home dialysis and what it means and how that patient feels. My current dialysis patient is usually very forthright and explains the good, the bad, and the ugly, but mostly the good and how they feel better and how they're able to do everything they need to do and how they're really going to be in and out of the clinic in a quick fashion and not be back for 15 to 30 days. This is a very powerful messaging tool when it's patient to patient, and I think without it, I could not have grown my practice to where it is today. So again, once the patient comes to the center, the contrast of seeing home dialysis versus in-center is also a very powerful visual. This cannot be accomplished in a brochure or an outside third-party educational model. I often do it very deliberately. I'll have the patient come in, meet a patient first, do the patient visit with me, leave those patients together to discuss home dialysis. At the end of that, and most of the time the patient, prospective patient, is coming with their loved one, spouse, or child, so they also get the benefit of seeing what their family member is in store for. Once they finish that visit with the home dialysis patient, I often give the prospective patient a tour of the clinic and show them what in-center dialysis is without any real bias, saying this is also an option for you in the event you choose not to do home, and this therapy involves coming to the dialysis center 3 times a week, 4 hours a day, where we'll give you a schedule. So without having to say anything else, the prospective patient sees the chair, how they're confined to the chair, the frequency of visit, and they also contrast that with seeing that home dialysis patient who tends to be very healthy, happy, and basically leaving the clinic as I'm giving the tour. So again, this is very deliberate, and our team also supports this by saying this is your 2 options, and more times than not, I would say north of 90% of the time, the prospective patient chooses home-based dialysis as their option number 1 if they end up being eligible for it. So to reiterate, I do this in a very deliberate fashion with the patient, discuss all options with them, but try to focus on how home might be better for them. The past year with COVID has been a big tailwind for us in home dialysis in that it's actually made our job easier in helping patients choose a home-based therapy to avoid potential exposures in the clinic. So we kind of have used that as a way to help patients who are on the fence potentially choose home dialysis. So let's transition a little bit to home dialysis selection or barriers to home dialysis selection by the patient. So again, as I spoke in the first slide, fear is the natural emotion of most patients who are told they need to be on dialysis. No matter how many times they've heard it in advance, once they have the realization that they're going to need dialysis, that fear is difficult to overcome, and it takes a long time for some patients to do so. I think for us as clinicians, it's very important to address and acknowledge the fears of the patient. We should spend time discussing them and really try to help the member navigate them. And I have found that many patients are afraid of bringing healthcare to the home, not because they can't do the therapy, but they're afraid or don't want to burden their spouse or children with healthcare in the home. And I think, again, we can all identify with that concept. We try to explain to the patient and the family that the family members often want what's best for their family member, and that CKD ESRD is a family-based illness, a family illness. It affects all members of the family, particularly adult children who are often the people who are caring for their parents and bringing them back and forth to an in-center dialysis center. So once the family members understand how a home-based therapy is better for the patient and also, frankly, better for the family, it's much easier to have that patient choose home dialysis. So to say that again, the home dialysis therapy allows the patient to be better, have better quality of life, and have the family have better quality of life because their family members at home, not going to the hospital or a center every other day. The family members can continue to work, or the patient can continue to work, and it just tends to build a better morale in the family. And lastly, probably obvious, but I'll still state it, is that there are no transportation needs for these patients who often have those hurdles to face. There's no waiting for a county or parish bus. There's no weather issues that eliminate a treatment or have a patient miss a treatment even if they want to come. There's, in my part of the country, with hurricanes affecting us regularly, and this past year was really bad for us, the ability to take care of yourself on the go without electricity is also a powerful motivator for these patients once it's explained to them. No one thinks about that till it happens, but those members who are able to dialyze at home are not faced with the dangers of having to travel to an unknown city or unknown hospital or lose power or get in a flooded environment. Geographic barriers. So I think there's an assumption amongst most people, including non-dialysis patients, that all hospitals, all medical centers, all areas offer everything, and this simply is not the case. Because a patient lives in a rural market or a market where home dialysis isn't offered regularly, does not mean that they should not be know about home dialysis. I hate to say this, but I feel that many times home dialysis is simply not offered to patients who are eligible for it because it's not offered by the clinic or the physician that patient got assigned to. I find this to be a pet peeve of mine, and I think it should not limit anybody's ability to do home therapy. All options must be presented to patients. We all realize that some patients cannot do home dialysis, maybe at the beginning, but I've had many patients who've started with catheters, received fistulas, gotten on their feet, started to feel better, and then we transitioned them to a home modality like peritoneal dialysis or home hemodialysis. So it should not be a one-time decision when someone starts, whether they continue in one modality or the other. It really should be a dynamic process where options are revisited about types of dialysis while patients are waiting for transplant. I've had many patients convert to home therapies from InCenter or from traumatic hospital-based starts because they want to get better and they realize that doing dialysis at home is something they can do once we offer them all the support that they need. Again, this can sometimes take days, weeks, months, even years to get to that point. But it's important to continue to revisit home options, even in our patients on in-center dialysis. Patients want to train and be seen at clinics near them. The beauty of home dialysis is that once you're trained, it's not as difficult to go somewhere that's far away once a month like it is to go to an in-center model 3 times a week. So asking about home dialysis centers in your area, even if it's a little bit distant, is a good way to get more people on home dialysis. Telemedicine is now approved by CMS in many instances, so that distance becomes less of a barrier to providing home dialysis. So I think there really is no excuse for someone not to be able to be trained in home dialysis. Nearly 3/4 of the patients in this country are seen by either Fresenius or DaVita, and those centers are pretty much all over the place. And the patient should be asking, or we should be helping that member find a center to train them. In my market where I practice, generally it's a very rural market, and not all clinics offer home, but we train even patients for other doctors in our clinic, and then the patients go back to their doctor. So it's not about a doctor and keeping a patient or patient keeping a doctor. It's about getting that patient what they need. And patients often don't even know this is an option. So I think that's not a good thing. And patients should know that they should ask about home dialysis, or their family members should be asking the doctor or healthcare provider about why cannot my loved one do a home-based therapy, and put that doctor or provider on the spot and really push them on this. Physician barriers. So again, there's always an assumption that physicians are well-versed in all different types of medical care and or home dialysis. You know, I can't tell you how many times I get asked at a party about knee pain or joint pain, and I really don't know much about it, but the assumption is because I'm a physician, I know a little bit about it. The same happens in dialysis care. Many physicians simply did not train or are not comfortable with home dialysis. And even though they should be offering that option to their patients, they don't try very hard. I think that this should not limit the access or choice of the patient. The patient ultimately is in charge of what therapy is they use, and asking the right questions is very, very important to getting to the right answer. So I hope after this seminar, webinar, all of you who are practicing in different parts of the country or have access to patients are helping empower them so that they know what questions to ask. A, am I on the transplant list? Many patients do not even know if they're on the transplant list. In my opinion, all patients should be referred to transplant and let the transplant center decline them if they have a criteria that eliminates them. We should not be deciding that for patients. 2, am I a candidate for home dialysis? Even if the physician internally feels like you cannot do it, that is really not without any kind of evidence. The patient should be pushing the physician and providers to ask, how can I eliminate barriers so that I can do dialysis at home? Again, it doesn't happen easily for everyone. We use transitional care units in dialysis centers to help patients get acclimated to home dialysis with the goal of at some point making it home. I have patients who we've trained in home dialysis who have a partner who's not available at the moment. They're doing in-center dialysis. They're cannulating their own arms. When that moment finally comes when their partner's ready, they're able to go home. I have patients who are on in-center dialysis who want to do home dialysis, and we have our monthly meeting and talk about it again and again, have patients go out to the floor and talk to them and help them convert to home dialysis. So we do some, propaganda is the wrong word, but we use tools to help patients see how much better their life could be on home who are good candidates. and we have willing participants in our existing patients who want to be ambassadors and help that patient make the decision that was right for them as well. So again, patient empowerment. Let's spend a little time on this slide because I find this to be very, very important. Demand more of the doctor and the care team. The physician and the patient should be in a partnership about their dialysis modality. It should not be the physician making decisions for the patient on what is best for them based on their own internal experience. We all realize that physicians and patients have different ways they look at this, and it should be looked at from the patient's point of view much more than it is now. 95% of physicians would choose home dialysis for themselves or their loved ones. Yet in the United States, only 8% of people to 10 are currently doing home dialysis. There is something wrong there. So if the patient pushes, they likely will get the answers they need. Paternalism does not work in this setting. So meaning the physician in their office visit should not be able to say, I don't think this patient can do home dialysis, therefore I'll not offer it as an option. Dialysis educational models should take into account all variables when it comes to encouraging home dialysis, transplant, or conservative care. Again, realizing that barriers can be overcome to get patients to home dialysis. Know your rights. I think this is a big issue here. Patients are often afraid to contradict the physician. They're afraid to ask for a second opinion because they're fearful of endangering that relationship with their doctor. If a patient has a physician relationship like that, they really should seek out another one. Physicians have to be secure in answering patients' questions and revisiting the ideas of changing a modality. Okay? And if a social worker or a dialysis nurse or a facility administrator is on this call, it's very important to help that patient navigate this challenging area. Many patients are seen by groups of physicians, and within that group, there's always physicians that are home dialysis champions. And if your patient in the center doesn't have one of those doctors, there's nothing wrong with telling that home dialysis doctor when he comes to do rounds or she comes to do rounds that I have a patient on the floor that's interested in home dialysis. And that way that patient doesn't have to be the initiator of the second opinion. And I've had patients of my own ask for second opinions, and it rankles you up a little bit at first, but we have to get over that issue because it's about the patient. Dialysis organizations are required to offer, and physicians to offer, all modalities to all patients and to discuss all options. So I'll repeat that. Dialysis organizations, as well as providers, are required to offer all modalities to patients. At dialysis center site visits, the site visitor can ask that question of a patient. If that patient doesn't know anything about home dialysis or transplant, that's a citation for the clinic and the physician. Additionally, transplant referral and discussion is a CMS requirement at site visits. Again, a patient must know that they have an option of transplant, and if the transplant center does not think they're a candidate and gives them the reasons why, that's okay. But we cannot decide for our members that they're not eligible for transplant. Once a patient sometimes finds out they're not a transplant eligible candidate because they're obese or they have other issues, they can have a surgery, a weight loss surgery. They can improve their diabetes. They can improve their compliance. But if we don't give them the option, their life expectancy is limited. So I think we must, as providers and dialysis centers, do a much better job of being open and offering these modalities and therapies to all patients in the clinic. And I think we're getting better at it. And as I allude to, the patients have to drive this. And I think the dialysis staff have to help the patients drive this. You know, in my clinic that I practice, my facility administrator is very, very patient-centered, as is our home dialysis director, nursing director. And they're constantly engaging with me on all kinds of topics of who can move to which modality, what's going on here. Can we get this patient's transplant referral done? Is there weight loss surgery referral? So we have to work together. And again, I'm talking in generalities here, but without amazing nurses and facility administrators and dialysis executives and others who support these missions, it's hard to accomplish these goals. So I want you to push those folks in your organizations to do better in this way. Okay, so let's talk a little about how the patient can be part of all of this. So each patient on dialysis is invited to the monthly meeting of the care team. Most patients do not take advantage of this golden opportunity, which happens every month. The ones that do tend to do better. They make us more accountable as physicians and care teams. We have to answer questions about their blood pressure, their transplant status, their dialysis status, their end-of-life status, and it makes us pay more attention. So, again, I'll keep pushing on the social workers on this call because they really are the glue of the clinics who really know what's going on behind the scenes and know what patients are telling them that are often not telling anyone else. And please encourage the patients who have questions or concerns in any capacity to participate in this meeting. It doesn't have to be a long meeting. They can bring the family. They get better care, period. Patients should tell the social worker that you want to attend this meeting, and specifically in the area of home dialysis, and ask about the options and how we can eliminate those barriers to get to that point. So I think patients, again, are afraid of doing this sometimes, and they may need an advocate like the head nurse, facility administrator, or social worker. Doctors simply do not feel patients can do home dialysis. We make, as physicians, a lot of assumptions about our patients, unfairly, I feel, because we don't get to know them as well as we should in these short office visits. And dialysis disproportionately affects patients of lower socioeconomic status all across this country, of which many people who are caring for them do not come from that same background. So it's important to not be judgmental and not assume anything. I've had patients in my practice in a rural, indigent part of Louisiana who are of high socioeconomic status, in some cases employed, and cannot do home dialysis because they simply cannot get it together. They don't roll with the punches. They don't deal with the setbacks sometimes very well. And I've had some of the least educated patients who are life smart, street smart, do the best at home dialysis because small things don't set them off and they're able to bounce back. So I've learned in my career over the last 15, 16, 17 years now that you can never assume if someone can do something or not. You can have a double amputee diabetic do home dialysis. You can have a patient who's got difficult vision do home dialysis. You can have a patient whose fistula is in the right arm and they're left-handed learn how to cannulate themselves if they're motivated. So let's stop assuming. Again, take control of your situation and ask your doctor why I've not been offered home dialysis. Am I on the transplant list? If so, why not? Because those types of questions make us uncomfortable because we should have done it. And if we don't do it, we'll do it that day. So I think that's one of the take-home messages from the patient empowerment arena. So we'll leave plenty of time for questions here at the end. So again, in summary, it's very important as a patient or a patient's family to be confident and advocate for yourself. You must be your biggest champion. You must ask the care team what you can do, how you can do it, and how we're going to get to that point. Not all dialysis centers offer all services. I'll repeat that. The dialysis center you're going to you may be assigned a unit for a multitude of variables that have nothing to do with you. It has to do with where there's a chair, where the doctor goes to round. If you're not offered home dialysis, it may be because the physician who rounded on you doesn't like to do home dialysis or does not want to do home dialysis or uncomfortable with home dialysis. That's not acceptable in my opinion. Trust your providers, but challenge them to inform you of everything. So if you ask your physician or nurse practitioner or extender, why can't I do home dialysis? They say, well, we feel that blank reason is the reason. You need to show me that you can come to the clinic and be compliant. I need you to lose 15 pounds so the peritoneal dialysis catheter is going to work. I need you to do this or that. Well, do that then, but make them give you a reason why you're not able to do that and how you can change those reasons or get the help you need. Home dialysis gives people freedom to live your life, be with your loved ones, and thrive. I use the example always of teaching patients home dialysis is like teaching a teenager how to drive a car. I have two teenagers. My son just started driving, and I recall a year ago when he got in the car, and when I learned how to drive so many years back, you're overwhelmed with all the dashboard and this and that and all the things you have to pay attention to. But with practice and a few mistakes here and there, within a few weeks and months, you're driving freely, you're changing the radio station, you're multitasking, you're doing everything you can do in the car, listening to a podcast, but it didn't take long to get there. But if you try to describe it in words to someone how to drive a car, it's very challenging. So I approach it that way. And after a few weeks and months, most, if not all, people learn how to drive. And the same with home dialysis. You must offer support to the patient and their family that they can do it no matter how long it takes. You will surprise yourself as a patient or a family member that this is something, I can't believe I didn't do this earlier if you're an InCenter patient. I'm glad I did it now. I'm glad I have time with my loved one and my spouse, all those things. So you can do it. You must think you can do it. I know you can do it. I've seen it firsthand. And as a patient, families want what's best for their loved ones. They don't want to see them suffer. And over time, it affects everyone in the family at different levels. So when that family member is at home and thriving, it helps the adult child feel happy for their mom or dad. It helps the spouse feel happy for their loved one, because this disease often afflicts people in their north of 65. So instead of being confined to a dialysis center at 65 or 70, now you and your loved one can still travel and do the things you need to do, or just be together at home and not be burdened with dialysis 3 times a week. I have patients who are over 70 on home dialysis. I have a woman, a wife, who has no medical experience at all, and within 4 weeks she was cannulating her husband's access, and he still can't cannulate himself because he's afraid. But she takes care of him. She's able to discuss with us in medical terminology what's happening, and most importantly, she brings cake and goodies to clinic every month because she's happy, her husband's happy, and we enjoy catching up. And she is a bigger dialysis champion than her husband. She'll talk to anybody I'll ask her to talk to and tell the caretaker how much they can do. So it's a comprehensive approach to being successful in home dialysis. Not all patients are candidates, certainly, but there are way more than what we're doing now. And I will stop there, Kathy and Hannah, and leave plenty of time for questions. I see there's a lot in the chat. Maybe I'll let Kathy throw some questions out if there's anything that was a theme. And I thank you for your attention today and allowing me to participate and share my experience with you. Thank you.
Thank you, Dr. Gupta. A lot of information that you gave. I'm curiously taking some notes. And I saw in the chat box there were some positive comments about some of the things that you were saying. And as you mentioned, some of them are not said very often. We did have a couple of comments or questions that were in the chat box, and we've got a good group of knowledgeable folks here who were giving responses back, but I will give you the questions.
Okay.
One question was, are type 1 diabetic clients eligible for a pancreas / kidney transplant?
Yes. So in type 1 diabetics, the issue is that pancreatic transplant, I'm not an expert in this by any means, but that's usually done from a cadaver. There's no living-related donor pancreas transplant from what I understand. So kidney transplantation can be done prior to pancreas if there's a living-related donor available. Someone's on the list, and when their number comes up, they would get the pancreas and the kidney so that they would not have diabetes anymore either. So in summary, if someone is a pancreas kidney transplant candidate and they have the ability to get a kidney from a living donor, they will get that first and still be on the list for a pancreatic cadaveric transplant. If they're on the cadaveric list, when their number comes out, they'll get both organs and essentially not have diabetes anymore. Hello? Hello?
It seems that we've lost Kathy,
Okay.
but I'm happy to take over and ask some of the questions that have been presented in the chat. Wow, a lot of you have answered each other's questions, which is excellent.
Yeah, I see that. Well, I'm looking at it too.
I guess, do you have any insight as to how maybe some undocumented patients would be handled with to have these options?
A very good question. So that's very challenging. In my own area in Louisiana, I currently have 4 patients right now who dialyze in our hospital who don't have any funding, and I have to work with the hospital currently to create a third-party arrangement between the hospital and the dialysis organization to prevent them coming to the ER, or not prevent, to help navigate them from ER to a home-based or in-center environment. So I think states have different approaches to this. In Louisiana, we don't have a great one. And so these patients, unfortunately, until there's some funding source available for them, and I believe some state Medicaid programs are more friendly than others, in this arena. Maybe someone else can comment on the call or on the chat if they have that knowledge. But in our state, they really don't have transplant eligibility or the ability to go to a dialysis center if they're undocumented. I know there's a lot of talk about this because those patients have worse outcomes. They cost more to the system, and ultimately just don't do well because they're not dialyzing efficiently. They're dialyzing under emergent conditions every time they come to an emergency room. And I will add, in the creation of these programs, it's crucial to partner, and our dialysis organizations that provide care in this country do a wonderful job, and it's key that as a physician champion, you push them to do more and to help you, give you the tools you need. One key to successful home dialysis programs is a dedicated home dialysis nurse or two who's not being overworked and not being pulled to do floor duties. So, when I built my program, our home dialysis nurse wasn't that busy in the beginning, but the center committed to the support for her to be successful, and now we've grown to a place where we have two. So it's also important that we work on systematic issues to create incentives and a push. The CMS, the U.S. government push, Medicare push to create more home dialysis patients has really helped in this way, so that dialysis organizations are much more in tune with the physicians now about creating the infrastructure necessary to do home dialysis successfully. I think there's some renal fellows probably on the call too. For them to be successful going forward, if they don't present, if they're not able to do home dialysis and take care of patients in that way, they will not be a successful nephrologist going forward. So it's very important that they learn that how to do home dialysis.
Hello, can you hear me?
Yeah, hey, yes, Kathy. Can you? Yeah.
Hi, this is Kathy. I don't know, I was disconnected before. A couple of other questions that have come in. One says that their biggest problem is transportation during training, that daily visit to the clinic. How do you handle that?
That's a good question. I think if it depends on the patient or their loved one. In our clinic, for example, our nurses, we try very hard. We sometimes extend the training period to accommodate the member. So, for example, if they have a spouse that works or can only come in the evening or on the weekend, between our two dialysis nurses, we try to handle it that way. We also try at times to go home and train if we can. That's an exception to the rule. And then I don't know about funding or other things that can be done to help with that, but I have found that in the dialysis world, if you speak to the director of operations for the dialysis organization or someone like that and say, look, I have two patients that want to do home, but they can't get to the clinic. There are often ways, creative ways to help that patient get to clinic, because the desire to create the home patient is great. And for the patient's perspective and the dialysis company's perspective, the home dialysis modality is better. So even if there's costs associated in the short term, I've found that there's ways that it usually gets worked out through the help of my regional director of operations in my dialysis center.
Okay, thanks. Another question is, how do you prepare the patient ambassador to share with the potential home patients? Is there a formal process that they go through?
We don't have a formal process. We just know the ones that are doing well and would be good champions. And like I said in the slides, we don't cherry pick the patient, the ambassador patient, in the sense that everything is perfect with them. I actually try to pick a patient who's had a few setbacks, some struggles, so they can attest to that, because we promise our patients, or we should be, all of us should be promising our patients an opportunity to be successful. None of us can predict who's going to have a rocky course or a smooth course when they start dialysis. But I assure all of my patients that if you jump on this journey with us, we're going to be supporting you through the whole pathway. And if you have a few bumps in the road, we'll overcome them. But you have to go into this with that attitude, because if you go into it with the attitude that nothing's going to go wrong, then you're going to be sorely disappointed if one thing gets set back. So I try to pick patients who may have been in-center and converted to home dialysis, because they can speak to both modalities. Or I pick patients who are just, are good communicators, but no formal training. And leaving them by themselves without me in the room or the nurse allows them to have a frank discussion. And to be very direct about it, I have the patient ambassador. I say, please discuss not only the treatment, but how you feel, how you sleep. Many patients have questions about their spouse, sleeping with their spouse, intimacy, things like that are challenging to ask the physician who does not know that firsthand. but that patient ambassador, I ask them to address these sensitive topics without the patient asking. And oftentimes it reassures that patient, because they don't want to ask that type of question, particularly about their spouse and intimacy and what peritoneal dialysis means or home hemodialysis means. So no formal training, but a little bit of encouragement to the ambassador. Please be frank, be positive, but don't sugarcoat it so that they think nothing's going to go wrong. So.
Good suggestions. Thanks. Another question. What are some suggestions to engage those nephrologists who may be resistant to referring patients to home dialysis?
So that's a very good question. So I'll speak a little bit. In my current role at Monogram, we encounter many physicians like this. So we use criteria to explain that this patient could do home dialysis after we visit them in the home. And then we engage with those nephrologists one-on-one. We call them and say, look, you have a member here who's been educated about home dialysis, can do home dialysis. So I'll answer it in two parts. One, sometimes the resistance from the nephrologist is simply based on physician bias and not understanding, assuming how their home environment is. So when they get told or educated about this patient's home environment is actually very stable, they have a loving spouse or children who can support them, they're motivated, then that resistance goes away from the referring nephrologist. In those physicians who still hunker down and don't want to offer that, it's time for the patient to cut them loose. It's time for the patient to say, look, I'm going to get a second opinion and see why I can't do home dialysis. I don't see why I can't do it. So it turns the tables a bit on the physician. I would say the first case is much more common when you're able to engage the physician and say, this patient can do this, this, and this based on this, this, and this, and the patient's family can do that. It doesn't have to be a company. The patient's family can do that. For an InCenter patient, a social worker can be that person. So I think it's much more positive. We don't have that much wholehearted resistance to this, 100% resistance, but it's a wave that's coming. Home dialysis is already here, and it's just going to basically take out any physicians who can't do it. So I think this will be a problem of the past coming up in the next few years, where the younger generation of nephrologists coming up are learning about home dialysis. It's being taught to them. They're much more open-minded to it. Some of the dinosaurs in nephrology are going to be extinct, frankly, in the next 5 to 10 years.
Okay, that's a good prediction. And certainly, perhaps learning more all the time. I know I still hear sometimes that people are being told, if you have a pet, you can't do home dialysis, or if you live in a small house, you can't do home dialysis. And
no, I think people will make adjustments to what you. So, for example, if someone has a pet, I'll ask them, "You have a pet?" Yes. Does your pet sleep in the same room as you or in the bed with you? Okay. Yes. Okay. Well, can that stop? Because if you want to do home dialysis, that's a no-go. Well, most people say yes. We'll find a way, or the spouse will say yes. We'll move the dog. Okay. Do you have a room in your house that is private where no one else goes into besides you and your spouse? Yes. Okay. It's kind of small. Well, that's okay. We can work on your supplies. We can find a way to have your shipments split up. You know, people are creative. We can't have barriers at every step of the way. So if we tell the family member, look, we need to have this much space to do dialysis, maybe they can keep the supplies somewhere else, at a neighbor's house or anywhere. But we need to give them the opportunity to eliminate the barrier. You know, if they have a job that involves water, you know, where I live and work, you know, patients sometimes work offshore in the Gulf of Mexico and oil rigs and things like that. Sometimes that can be a deal breaker because they just can't keep the area dry. But there's very few barriers that they can't be fixed for someone to do home dialysis. And if someone frankly chooses their pet over home dialysis, you know, I'm going to have a hard time convincing them otherwise. So as long as I think we've explained everything in detail, most people come around and say, okay, I got it. I can do this. I can find a way to love my pet and do home dialysis and be better off in both areas.
Right. Okay. Here's another sort of question comment. So someone's saying that right now they're having an issue with their chest cath. For some reason, the red line is somehow blocked, or should say partially blocked. I don't know if you can see that one of the chat box there. And wondering how to handle something like that at home.
Well, that's not something they probably can handle at home without knowing all the details. But if that's the catheter used for dialysis, it probably needs to be revised. More importantly, catheters should be temporary. So hopefully this patient or a family member who's related to the patient has a plan to convert to a fistula or a peritoneal dialysis catheter soon. Central venous catheters, unfortunately, 80% of people in this country are starting dialysis with a catheter, and there's a very high risk of morbidity and mortality at 90 days, and almost a 30% mortality at 12 months with a catheter. So that's not every patient, but that's all comers. So this patient or member should really be reaching out to their nephrologist quickly, or head nurse at the clinic, about what they can do to be referred to a vascular access center surgeon, and more importantly, what the permanent access plan is.
Okay, thank you. There's also the question, would engaging community health workers from community health centers to help educate CKD patients on dialysis modalities, would that be a helpful strategy?
I think so. I think there's an interesting issue we're dealing with right now, is that most education is being done by dialysis providers. So, as I mentioned, dialysis providers are crucial in providing effective therapies, life-saving therapies, but patients also need to be educated not only about home dialysis options, but also about conservative management options. If you have a loved one who's north of 75 and is frail and has congestive heart failure or COPD or another medical illness, they don't belong on dialysis, frankly, because dialysis might actually shorten their life. So I think a combination of education from the dialysis organization, physician and team, and other community-based organizations is crucial to having that member know all of their options, which can sometimes include not dialyzing. And if the dialysis is an option, home dialysis really should be not only the first, second, to me the top 5 options, even if you arrive at it later. So I think one of the big mistakes we make in nephrology in general is that it's one and done. So a patient ends up in center, that's their fate forever. Never revisit that member to see if they can do home. Like I mentioned in the presentation, COVID has allowed us to re-engage many patients who we thought would be good home dialysis patients but resisted early on. Now the fear of COVID and other communicable illnesses has become real, and those patients now say, I'll go home. Remember you told me about home dialysis? I'm interested in hearing more about it. And I forgot to mention during the presentation, it's very important for patients who are in center, if you have a patient who's doing self-care or doing home hemodialysis training, to do that in an area where other people can see them, like meaning one of the pods in the clinic. That engages other patients to think, oh, wow, I didn't think you could even do it at home, A. Or B, look at that patient. They were sitting next to me before. Now they're doing home dialysis. I want to learn about that. So again, kind of the classroom phenomenon of seeing one student doing something encourages other students to do something. I find the dialysis center is a lot like that, where if you have a positive experience where one person is doing something, other students / patients want to also say, why am I not doing that? How come I can't do that? So, well, you can do that. So I think those are some of the tools we can use to educate at every level, pre-dialysis, on dialysis, and then even in those members who might need medical therapy for ESRD as opposed to dialytic therapy.
Great suggestions. Any other questions? I don't see any other questions in the chat box at this point. I do think you've given us lots of information. You've answered a lot of questions. And I want to thank you again for participating with us today and joining us for this hour. Thank you so much.
Thank you, Kathy, and thank you, Hannah. And I just encourage all the people on the call, if you have a connection to your local National Kidney Foundation or any organization like that, any community-based organization, please participate, help. They welcome the volunteerism. The NKF loves when patients on dialysis want to help and be patient advocates. In Louisiana, we have a patient advocacy service really where patients can connect with other patients. And if you've had a transplant, any stage of kidney disease you're in can be helpful at the National Kidney Foundation state chapter and really help other patients navigate this complicated process. So again, thank you for the invitation today. I really enjoyed it.
And thank you. And please, everyone, if you'll complete the feedback form, and I want to remind you that we have our next webinar scheduled for May 27th, and it will be on finding joy even with loss and grief. We have a psychologist who will be joining us then. So I hope you'll consider spending that hour with us on May 27th. On one last note, anyone who wants to join us for our telephone support group meeting, it will be on May the 11th at 3 p.m. You can find more information on our website. And again, I just want to thank everyone for sharing this hour with us. Thank you so much. And if you have any additional questions, you can send them to info on our website. And Dr. Gupta, thank you again. And thank you, everyone.
My pleasure. Thanks.
Thank you.